Are we ready to start?
Yes, please. We are waiting for your presentation.
Okay.
I already give a little bit information about Pelvic Academy and what we would like to achieve. Now the ball is on your side.
Okay. First of all, assalamu alaikum to everyone there. I know we are at a very particular moment of Ramadan. Right now here in France, we haven't break our fast, so I will, in a couple of minutes, probably in 10 minutes in France, we will break our Ramadan. And I hope there you have been starting already your iftar and you're enjoying with your families. So today is a special day for me and for you, since we are going to take opportunity to share our experience and so that our patients can benefit through our experience. First of all, I would like to thank a lot the Pelvic Academy in Istanbul, in Turkey, who have organized this wonderful meeting, because I know there are a lot of friends, doctors, physiotherapists, and experts in Turkey who are watching right now online, but there are others also in different countries in Europe, in Asia, and probably in Latin America who are watching as well online. So first of all, many thanks for all of you to take precious time, and I hope that our first online meeting will get, we will reach our goals, which is to share our experience. Our topic actually is going to be dynamic pelvic floor rehabilitation using electrical stimulation and biofeedback. I will introduce to you, so I will put some slides, and then if you have some questions while I will be speaking, so feel free to put your questions on the Q&A place there, so that when I finish, I will try to read some of your questions and to try to answer them as soon as possible. So our meeting, I'm not going to use too much time, so let me go direct through our main topic of today. So first, my question, can you see the picture and the image? Is it clear for everyone there? Okay, excellent. So as you can see, my topic is dynamic biofeedback and electrical stimulation for pelvic floor dysfunction patients. So I am Dr. Abdallah Ndongo. I'm an obstetrician and gynecologist in France, in a hospital in the southern of France. We call the center of Bagnols-sur-Cère. Our hospital, we have patients in gynecological problems and some patients who have also obstetrical matters. So we deliver both to all the patients coming from different parts in France and overseas as well. And also I did some studies in the pelvic floor. This is why I'm going to share with you my experience, and while I'm using my platform in obstetric and gynecology as well in the pelvic floor rehabilitation area. So I will try to share with you my experience, and so that we hope that a lot of patients in your country, in different parts around the world, they are going as well to benefit through these new vision in the global view of the pelvic floor, and using the best treatment as possible. So another thing now, my first slide, as you can see here, I am going to show you first the first part. I will talk about the complexity of the pelvic floor dysfunction. We are going to use about one hour. I will try my best. I know this topic, it's a hot topic. I'm going to use a lot of some new things which I have found recently. I will share with you. I will try to maximize the time so that I will not take too much time from you guys. I will do my best to remain in 1 hour. If we can go further, why not? I'm ready to share with you. The first point I will talk is going to be different kind of guidelines and some new articles about the pelvic floor dysfunction rehabilitation using different kind of techniques and treatment. I picked some guidelines. The third point I will talk about also the particularity of pelvic floor rehabilitation here in France. it's a little bit special, so that I think it's good to talk about the history. Where do we come from, and what are we doing? What are we doing now, and what is the future? So I will try to share with you, and I hope that people can also benefit through the experience we are having here. On the fourth point, I will be talking about the application of biofeedback techniques and electrical stimulation to try to solve the matters when it comes to pelvic floor dysfunction. What is biofeedback? What are we going to do in the biofeedback? What are the advantages in the biofeedback? And what about electrical stimulation? So I will try to use both these two specialities together to try to give such a multidisciplinary approach when it comes to pelvic floor dysfunction, non-invasive treatments. And I will be talking about how should we approach. Of course, I'm not going to teach you how to approach the pelvic floor dysfunction. I know you got a very good experience, but what is here we are going to do is to try to show that besides the surgery we are doing every day, beside the medication we give to our patients, there is also another option, which is very important to combine together so that this patient really can get what is necessary at the right time. And then I will finish with the conclusion of our topic, and I will come to the questions and answers for the last part. So another thing now, for the first point, let's talk about the complexity of pelvic floor dysfunction. Actually, let's look to the pelvic as a global picture around. So this picture is famous. A lot of people have been talking about this around the world. So as you can see on the left side, we have a kind of a shape which is well staged at haba, at the right part, I mean, and we can see there is some water. So here, this represents some kind of ligaments, we can say, and different kind of fascia of the pelvic floor or pelvic organs. We have also these organs in the mid. We keep the balance because there is all the stability around it on the right area. But when we look to the left picture, we can see there is no water. That means the different kind of, for example, ligament or fascia or support of the pelvic floor are not doing their work anymore. They lost their functions. And what's going to happen? The organ will find itself in an unstable environment. And whenever it's windy or whenever there is a problem, the patient is coughing, or whenever the patient is jumping and sneezing, then this organ might lose balance, and then the patient is going to present different kind of symptoms. So here, as we can see, on one hand, we have support elements, like, for example, muscles, fascias. On the other hand, we need also to have the support of the ligaments and different kind of fascia around this organ. Pelvic organs need everyone, each part must play its role so that this organ can have a normal function, whether it's a female or male. It's so important for these elements, these organs, to remain at the right place, but also to play a normal role when it's come to the function. So I'm going to share with you by looking to the pelvic organs and all the environments as a team. Just imagine a football team or a basketball team. So this team has different players. So these players need to play their role so that this team can give the best performance when it's come to the competition. I'm talking about competition here. I mean, our daily life is a kind of a competition. Every time we go outside, we're going to carry heavy stuff. We are going to sneeze. We need to run, to jump. There are a lot of changes when it's come to the thoracic area, to the abdominal, as well as to the pelvic floor. The whole body in general is going to face these changing on different environments, and these organs are going to suffer sometimes. I use the word suffer here. Whenever they lose the balance, it's becoming suffering. And this patient later on will develop the symptoms, whether it is incontinence, when it's urinary incontinence, fecal incontinence, prolapses, pelvic organ prolapses, or even when it's come to chronic pain, neurological dysfunction, and so on. So here we will look to the pelvic floor or the pelvic as a team with a lot of players. The players we will use are the ligament and fascia, the conjunctive tissue, vascular systems and neurological, pelvic floor muscles. The coordination of everyone to play the role is so important, so that this patient, this person, this human being can remain in a normal condition. So a first player I will be talking, player number one, is the ligament. These ligaments are so important. For example, when we look to the uterus has the round ligament. There is the sacral ligament. We have also the cardinal ligaments. So for the uterus to remain at the up position, right position, it is necessary, it is important, this ligament to play their normal role. It's same also when it comes to the bladder, to the rectum, and the anal. So pelvic organs, they need these ligaments to keep the stability. Player number one, very important. We need ligaments to remain at the right position and to remain to be smooth. Their elasticity has to operate in a normal range. Whenever they lose the balance, these organs is going to move in different way, and that can create some problems when it's come to the function. Player number two is the perineal fascia and the myofascial channels. The myofascial channels, as you can see on my left side, we have from the back part in yellow, we have also on the right part. These channels cross together into the pelvic area. So whenever a person loses balance at the upper parts, this imbalance can have an impact on the pelvic and create some problems. So we need this fascia to play a normal role. Player number three, we need also the deep pelvic floor muscles, the pivovagina muscles, pivorectalis, pivococcygeus, iliococcygeus, ixiococcygeus. These muscles in the deep pelvic floor are very important. With their function, these organs will remain at a normal range, or we can call a normal environment. We need their function when it comes to their contraction and their relaxation as well, so that these organs, whether it is the bladder, whether it is the uterus, whether it is anorectal, they can remain in a normal function when it comes to close. When we, for example, there is a gas coming, we stop the gas, or whenever we need to void. All of these functions also are related to the deep pelvic floor muscles. Player number four, very important, is the superficial pelvic floor muscles. We have the transversals, superficial transversus muscles, bulbospongius, ixiocavernous, and the sphincter in the anal area. These superficial pelvic floor, which are completely different to the deep pelvic floor, we see on this picture, they also play a very important role, especially when it's come, for example, when you're sneezing or coughing. It's important for these organs, these muscles, to help to increase, the urethral closure pressure, or when it's come to the sexuality function. We need also their function so that the person can have a normal function. So we need a superficial, player number four, superficial pelvic floor muscles. They are very important as well. Player number five. The player number five is, we will talk about the connective tissues. This is the fatty tissues you see here. They are not there just for nothing. These fatty tissues, they play also a very important role when it comes to decrease the internal pressure when we are sitting or when we are falling down. These contacts, when we fall down, the impact of our weight on the ground, the shock, we need these fatty tissue to try to reduce the shock so that the internal organs can be in a safe environment and play a very important role. So we need them to be there. Player number five, connective tissues. Player number six, the sacrococcygous area, the bone part. Not only the sacrococcygous, but also the pubic bone, the iliac bone. All these bones around the pelvis, they are also important For example, on my experience, when it's come to my experience on patient giving birth in my department where I work as an obstetrician, we all know that there are some patients after giving birth, they can suffer from coccygodynia, the pain on the bone tail here, as you can see the coccyx. Sometimes during the delivery, the head of the fetus, of the baby, can press and destroy, we can say, the balance between the coccyx and the sacrum. And this, whenever this joint is destabilized, the patient will start to develop very, very deep pain. These patients sometimes have difficulty to sit down because it's too painful. The muscles will find themselves in a hypertonic position because these muscles in the deep pelvic floor, they are connected to the pubic bone as well to the coccyx. So we need these parts as well to remain in a normal range and to play a normal role. Player number 6, very important, the sacrococcygous region. The player number 7, which also is very important, are, for example, the vaginal walls, whether it is anterior or posterior vaginal wall. These walls, as you can see from the lancet, these parts, it's the 3 levers, they're very also important. We need their stability. Their stability is also connected to all the organs, the players around the pelvic area. So we need these part also to remain in a normal part, in a normal region. We know this vagina, posteriorly we have the rectum, anteriorly we have the urethra as well and the bladder. So whenever, for example, the patient develops a cystocele, of course it's the back part, the posterior part of the bladder, which will come to press the anterior part of the vagina and create the symptom of prolapses. So it's important for different kind of walls connected to these ligaments and to the conjunctive tissue to remain in a normal position so that it can help also the organ in the upper part as well as in the lower part to be in a normal position. Player number 7, very important, vaginal walls. So as we have defined 7 different players into when it's come to the pelvic floor team or the pelvic team, when we talk about the team, we need also to respect the game, the rule of the game. Every player at the right place. This is what I was talking. We need a normal anatomy, but remember this, normal anatomy does not necessarily mean normal function. These are complete different concepts. But we know that whenever we lose a normal anatomy, we are at higher risk of developing some symptoms. So we need normal anatomy position to guarantee or to have the chance to have a normal function. So every player needs to be at the right place and play a normal function so that the person can be in the right and safe environment out of pelvic organ dysfunction. So this picture sums up all what I was talking about, the 7 players, which are so important for us to play the important role so that this person might, whether it is a female or a male, might not present a different kind of pelvic organ dysfunctions. There are also some muscles I did not talk in my previous analysis when it's come to the 7 players. For example, the internal obturator or the piriformis muscle. These 2 also, they are also a part of the deep pelvic floor muscles. You remember, I talked about the player number 3. It was the deep pelvic floor muscles. So the internal iliac, especially, and the piriformis muscles, they are connected to the low limb. They are also connected to the levator ani. That means the deep pelvic floor muscles. They are also important. Whenever they are hypertonic, we might have the same problems when it comes to this region. So we need all the players to play a very important role so that the functions can be guaranteed. Very important as well, we need to remember, as I said, that normal anatomy is one important point, but there is also a very important thing I did not talk about, the neurological part or when it's come to the vascular system. They are also the players of this team. They help to coordinate different organs so that they can play a very normal or a very important role when it comes to the patient jumping, running, and keep the balance. We need some reflexes. For example, in pelvic floor, we talk about the pre-contraction reflex. When I cough, before coughing, like 1/10 second before, my pelvic floor in general, globally, has contracted before even coughing. But whenever we lose the pre-contraction reflex, whenever we lose it, sometimes you cough and then it's too late, there is already a link. So we need the reflexes. So this is the pre-contraction reflex. We need also a myotatic reflex. What is it? Myotatic reflex, any muscles. Whenever you stretch it to a certain limit, when it reaches a limit of elasticity, these muscles will react. That reaction that we call the myotatic reflex of the muscles. The same way, whenever I put too much intra-abdominal pressure, this pressure will go into the pelvic floor. The pelvic floor muscles and the organs around, they will be stretched to a certain limit. If they are in a very good environment with a good function, they will create a myotatic reflex so that this patient can have a defense. Sorry, a defense. So I'm going to take just a few seconds to break because it's time for me here in the middle of the Ramadan. I'm sorry, just for 1 second. Done. So we need the two reflexes, pre-contraction and the myotatic reflex, to help us to do what? To participate so that this team and their players can perform in the best way. And the pelvic floor dysfunction in the global view. So I will give you, I know that everybody knows about this. We have different kind of problems when it's come to anteriorly, for example. Anteriorly, we have the bladder and the urethra. In that part anteriorly, we will have the stress, urinary incontinence, overactive bladder, mixed incontinence. We have some symptoms like post-void revusio, hypoactive bladder of the detritus, urethral hypermobility, or dyssynergia when it's come to the bladder and the urethra. In the medium part, we have different kind of pelvic organ dysfunction, like for example, prolapses, cystocele, hysterocele, rectocele, or enterocele. We have also some sexual dysfunction, which I put in the medium part, but actually it generally can affect psychological and the feeling of the patient and the relationship when it's come to the husband. But it's so important here, this sexual dysfunction can have an impact when it comes to unstable or destabilized pelvic organs or environments when it comes to the reflex, contraction, and so on, and the patient can have the symptoms when it comes to sexuality. So it's so important whether we will give a surgery or not to understand also before we give the treatment to this patient, do they have some sexual problems? So it's so important to open up such a subject. I know different countries with different regions, they take this matter differently. But if we have to take care of the pelvic floor globally, it's so important to pay attention to all the organs, their anatomic function and their function, as well as different others function, whether it is sexually and so on. When it's come to there are also a very common problem we often, the chronic pelvic pain. This is also a hot topic when it's come to ops and gyne or urologist or gastroenterologic as well. We know it's so important sometimes to help this patient, because if we don't save them, if we don't resolve the problem of pain, the other functions can have the consequences. For example, whenever a patient has, for example, a deep chronic pelvic pain, most of them, they have a kind of hypercontractility, hypertonic of the deep pelvic floor or superficial pelvic floor muscles. Because these muscles are going to find themselves in a hypercontractility position, the nerves in the between are going to be the nerve entrapment. So if you don't solve this problem of pain, this patient might develop constipation or might develop post-void residual, so it becomes anterior leg problem or posterior leg problem. So it's so important to pay attention to this part as well. Posteriorly, we have anorectal dysfunction, whether it is anal incontinence, constipation, microrectum when it's come to the symptom, megarectum, or anorectal dysfunction as well. Do not forget as well, we talk about the pelvic floor. The pelvic is also connected to the abdomen. It is also connected to the thoracic. It is also connected to a normal posture. If the person is not in a very good posture, daily life, this person might develop some imbalance left and right, or when it's come to the intra-abdominal pressure, increase for a long period of time on the life term of this patient, and later on, this patient might develop some pelvic organ dysfunction. So it's so important to have also the vision to take care of the pelvic floor. We need also to use different kind of connection whenever it's come to the pelvic floor. Thoraco-abdominal pelvic dysfunction. My second part of our topic, I will just throw different kind of guidelines or ideas coming from different kind of articles. You are also free to search and to read those articles. I think this online today is gonna be, you will have a free access to this meeting later on so that you can read those articles. So I tried to bring some new ones so that people can have a good view. Early, this is over 20 years ago, even the World Health Organizations, they also organized called the first international meeting when it comes to the incontinence in 1998. You can see this is just yesterday, but do not forget that the pelvic floor dysfunction has been there since a human being has been on earth, since we decided to stand up, to become biped, to walk, not to climb. Since we decided to stand up, we have created a kind of instability, a kind of instability into the pelvic region. So the human being has been standing and walking and jumping since he has been on earth. The pelvic organ dysfunction has been there. So you can see just yesterday, 20 years ago, the World Health Organization started to talk about incontinence, but to tell people just this topic, it's still a mystery, and we need to talk about it if really we need to improve the quality of life of our patients around the world as well. Another thing here, we can see the problem is so important. In the 90s, WHO as well has launched a wide program of preventive of incontinence. Is so important. The keyword for me here is about the prevent. How can we prevent the pelvic floor dysfunction to occur? It's so important if we understand that everything is, all of these players are interconnected and connected to the thoracic, abdominal, and our posture. If we integrate this vision of the pelvic floor globally, we will understand that sometimes the problems from the pelvic floor area originated from extra pelvic floor, not necessarily from intra-pelvic floor. So it's so important to look to the patient globally, not just locally, whether we are gynecologists and obstetricians. It's so important for us to pay attention to the posture of our patients, how much weight they gain during their labor, during their delivery, how do they deliver their pregnancy, and how do they deliver, do they have some problems, early treatment, better outcome. So it's so important. And also I would like also to share with you this article just about 6 years ago when it comes to the pelvic floor and the fecal incontinence. We can see that even then they thought that it's so important to pay attention to these topics later on you can have a quick to that. We have also the pelvic floor physical therapy in the treatment of the pelvic floor dysfunction in the women. This is just last year article from United States. Here, as you can see, they published it, and even from there, when we look, it's the evidence support and the clear benefit as the first line treatment. Even here in France, we believe that pelvic floor rehabilitation is the first line. Why? I will come later on to explain, because of its characteristic, but I cannot answer it now because I need to give a clear picture of what is the pelvic floor rehabilitation. Later on, I will talk about it. But we can see they believe also themselves. It should be a first line of treatment. The first line means that we have less complex complications. We have less side effects. We have less consequences. And then whenever you use it, sometimes you can have the benefit to the other treatments you will give later on. So important to think about that point. We have also this article, which is a recent article in just last year. It was published last year. They talk about the effectiveness and the cost effectiveness randomized control trial of basic versus biofeedback mediated intensive pelvic floor muscle training for female stress and mixture urinary incontinence. So they use the different kind of the technique of biofeedback, because we will talk about biofeedback. We will talk also about electrical stimulation when it comes to treating incontinence or different kind of pelvic floor dysfunction as well. This article, whenever you have time, please have a look at that. In France, they published also another article when it's come to, it's in Paris, a university in Paris. They took the patients who have their pregnancies and then to try to see what is the impact on the pregnancy on the anorectal dysfunction. So it's so important because we know during their child bearing, this patient can gain weight, but also we have also delivery. So especially in France, when it comes to the delivery, natural delivery in France, it's the rate is about only 19%. It's cesarean section, over 81% is about natural delivery. I repeat, in France, cesarean section CS, the national global, it's just 19%. The place I work, for example, we advocate more about natural delivery. In the hospital where I work, we are about 12% of cesarean section. So we have over 88% about natural delivery. So we know also natural delivery is so important because it's not because patients can give birth naturally so that they will develop a pelvic floor dysfunction. But it's so important to prevent it, to try to diagnose it early, and to give the right guidance to the patients, and then so that they give birth in a proper way so that we can avoid these complications. So remember this, naturally, women should be giving birth naturally, not by CS. When it's necessary, we need to go through CS as well. We need both together when it's possible, naturally, but we need to provide the whole package to the patients, following up, try to treat them nicely, prevent the pelvic floor dysfunction so that later on their quality of life might not be affected by that. And these guidelines and the study also was talking about using electrical stimulation and treating different kind of, when it's come the TENS treatment of electrical stimulation. I will talk about it later on. This is another article. We have also a guideline from Netherlands, Dutch, and one of my friends who worked on it just about 9 years ago, but each year it has been also published in different languages. It's so interesting to have just a picture about that. I will come through my third part of our meeting today. My third part is gonna be about the particularity of France. How do we do it here in France? How does it work here in France? It's important to have the history. First of all, as you can see on this slide, The history about the pelvic floor, first, it was the idea, pelvic floor rehabilitation, it was the idea about an American doctor, Arnold Kegel. He has the concept. For him, he believes that in our body, we have different kind of skeletal muscles. These skeletal muscles in our body, we have also them in pelvic floor. All of us, we often do exercises every day to strengthen our muscles. He believed that, Dr. Kegel, we need also to strengthen our muscles to avoid pelvic floor dysfunction, because he knows patients, they are suffering from pelvic floor dysfunction. Why don't we train them? If we train them, maybe we will increase the quality when it's come to these muscles into the pelvic floor. Kegel has that mind, that idea. But for him, he thought, we just tell the patient to go home, lie on the bed, think about the pelvic, and start to squeeze and relax for a few seconds and repeat such exercise many times daily or a few times a week. That was the idea. He created that mind. He gave us the idea. We need to go to work. But from Kegel's perspective, he did not know how the patient performs. When you ask a patient to contract, does really this patient, is she or is he contracting or pushing? Later on, when it comes clinically exam, we have found that there are some patients, when you ask them to contract, actually they are pushing. So there is a reverse of the current. This is so important, but from Kegel, first for him, he just said, ask the patient to go, contract and relax. But if we never go to put our finger there or to get the signal of electromyographic of the muscles, or to see what kind of pressure increasing or decreasing in the pelvic area region, it would be very difficult for us to really ask our patient to train at home so that they can train properly. This is how the idea on pelvic floor rehabilitation started to develop. In France, there is one expert named Alain Boursier. In the 80s, late 70s, and beginning of 80s, he went to France. From France, he went to US. He met this guy, especially his wife, and he found out, wow, this concept of trying to ask the patient to train their pelvic floor muscles so that they can decrease different kind of symptoms and improve their quality of life. This concept it's genius. We need it in France, because at that time, no one was talking about it. So he came back to France at the early 1980s. Then in France, what they did with Alain Boursier, they first called it urogynecologic pelvic floor rehabilitation. In 1980s, they created the first big meeting. Later on, just 5 years later, after they present the case to the National Health here in France, later on, there is a law which was passed, and there is a decree number. You have here the references. Since at this time in France, every woman, whenever she gives birth, she will receive an ordinance of pelvic floor rehabilitation after birth in postpartum. Up to date, myself, each patient after giving delivery, I will prescribe it, and it is covered 100% by the national insurance. So to tell you that we believe that these patients, if we wait until they get their menopause, if we wait until they get old, we know also their hormonal level will decrease. We will find this patient at a very severe matters. It's gonna be very difficult. Maybe all of them have to go surgery or using some invasive treatment. This is why we believe that early treatment, it's better. And in France, before we started with old people, then we went to postpartum. Right now, even patients who, before even getting married, they can have the assessment. If it's necessary, they present symptoms, we try to provide a treatment. We don't wait until they are in postpartum to give them the right treatment. So remember this, we help these people. Whenever they present, they are at high risk. we give them the right treatment before, and it is also undercovered by the national insurance. Of course, I respect every country, they have their policy, but this is the experience we have in France. And then with the development of the technology now, from the Kegel concept of just imagining, thinking, ask the patient to contract. Later on, we develop tools which can help us to see exactly how does a patient performing. Is it really a contraction? What is the amount quantified a contraction using biofeedback techniques? If it's necessary, we use a passive way to help them to contract or to relax by electrical stimulation. This is my first part of the topic. I'm going to introduce now the application of biofeedback and electrical stimulation techniques when it comes to pelvic floor dysfunction. What is the place of instrumental pelvic floor rehabilitation? First of all, instrumental pelvic floor rehabilitation is just an extension of the hand of the therapist or the doctor. I repeat, I use a probe like the vagina probe because I cannot put my finger there for 30 minutes. So the probe can be there. I can capture the signal of the contraction of the biofeedback, put it in the computerized, and then generate it into the curve, which it's gonna be easier for me to analyze and also to guide my patient to perform the right contraction or the right relaxation. Without the biofeedback, patient cannot see what they're doing. The doctors or the physiotherapists, it's gonna be difficult for us to evaluate how do they perform. How can we help them to prevent if we don't understand how do they perform? At the early part of pelvic floor rehabilitation, everything was manual. It's so important to do manual. I'm not saying we should stop doing manual. Manual examination and assessment and the treatment are available. We need them because they create a kind of a bridge between the physiotherapist and the patient. But we also need to help this patient to excel, to go further. This is why the technology has helped us. So for me, using different kind of probes and patches or electrodes, it's just an extension of the hand to help the physiotherapist to understand better what's happening inside and to guide the patient to do the right exercise at the right time. It provides different tools. We use electrical stimulation, biofeedback, and using even dynamically with different kind of posture. Here I give you a picture of different kind of tools we use. First, to get the signal, like the biofeedback signal, EMG, from the pelvic floor muscles contraction, or I can use also the pressure, manometric pressure, biofeedback, to get the pressure into the vagina or into the rectal area, male or female, so that I understand if the patient cannot contract, I can use electrical stimulation because you see the metallic part. We use electrical stimulation, we can send the current, we can choose the type of the current according to the type of the pelvic floor muscle fibers to contract them or to relax them. All of these has been developed, these techniques. Now it's up to us. How are we going to use them, to apply them, to help us to provide the best kind of the treatment? We have even a dynamometer here. It's a kind of speculum. We use, here we have a captation of the tones, the force in the Newton, the force, it's a dynamometer. We can also calculate the strength of the muscle. You see how the person started, the treatment. Where was the patient? After a few kind of treatment, you can do another assessment to see the improvement, or there is no improvement. You need assessment. You need to have such a scale which will help you to understand that your treatment you're providing your patient is working or not. Of course, you can tell me, I can understand if it's working whenever the patient is having symptoms or whether the symptoms of the pelvic floor dysfunction reduce. But remember also, if you wait until you see the symptoms, it's too late. If you remember the 7 players we talked before, these players, they work together. Sometimes they're not working in a proper way, but this patient does not develop yet symptoms. When the symptoms occur, normally it's already too late. When I say too late, it means that it's reached to a certain severity before this patient now start to have symptoms which will affect the quality of life. So we need these tools, just like the instrument we use for surgery. Before surgery, we do MRI. We can go to ask the patients to do ECG to understand how his heart is working. We need the signal of the ECG to understand how does this heart working. Do we need to give the drugs or not? It is the same principle. We are using the same tools, but the good news about these tools, they are non-invasive, almost do not have a side effect. It's not like medication. Of course, any tool you are using clinically, you need to master its indication, how to use it in the proper way. If you respect all the guidelines, normally speaking, you are not going to have the same side effect as when it comes to surgery or when it comes to the medication. So remember, these tools will help us to cut the signal from the patient to the screen, or also to provide electrical stimulation from the device to the patient. So we use both ways to help our patient communicate. But more interestingly, it's not just the physiotherapist or the doctors ask the patient to do such exercise or not, but the patient will participate actively. They will see how do they perform, how do they do the contraction. It's so easy for the patient when you ask them contract, relax, they will try their best to do it, but can they understand how much do they do? If you put it on the screen, it's become easier. It's the same way we did for the ECG. If we did not take the ECG signal and filter it to give us the one we understand whether this patient has a normal heart rate, beat, and so on, we are using the same in the biofeedback. Just different area, different region, using different tools, but the principle remains the same. What is electrical stimulation techniques here? First of all, this principle, as I said, we use electrical stimulation, of course, at the normal range of the human body. We send the signal, we stimulate the neuromuscular, and then this patient will create a contraction. A contraction is a function because in our daily life, we need to walk, to carry on, to take something, to put it here. So we need to contract and relax in coordination. But remember, when it comes to the pelvic floor, sometimes after delivery or after trauma or after surgery, these muscles will lose their normal function. So we need to help them to regain, to come back to a normal function. So we use a passive way, which is electrical stimulation. The objective is awakening of the proprioceptions function, reinforcement of the pelvic command passively. We can treat them also analgesic whenever they have pain. We can use electrical stimulation to drain vascular systems. We can also help them to relax. It's not only about contracting. Remember, if you need to have a good contraction, you must first have a good relaxation. If you're not relaxed, you're not going to perform well. So we use also electrical stimulation to help them to relax. Those who have pain and hypercontractility, electrical stimulation, some type of electrical stimulation we call tonalize, which is a very low frequency like 1, 2, or 3 hertz, with a wild of pulse about 150 to 250 microsecond. We use such parameters to help these muscles to relax, which is completely different to another stimulation for contraction. We use different type of currents, some of rectangular biphasic currents. We use interferential currents. We use also the drainage current for the vascular system. We use different kind of probe to reach and the patches externally to reach the region. The parameters we are using when it comes to electrical stimulations, we have, first of all, the muscles, whether it is a deep pelvic floor muscles or superficial pelvic muscles. These muscles, they got muscle fibers. We have different kind of fibers. There is the so-called fast fiber muscles. They contract very fast and they relax. And we have the tonic ones which have a good endurance. They can contract not powerfully, but they have the endurance. So we can selectively choose different parameters to help which kind of the muscles are not working properly. After the assessment, we will know this patient has a weakening of the phasic fiber muscles. So I'm going to choose whether it is 2A or 2B, which are phasic, such kind of frequency, such kind of word of path in respect to the time of work and stimulation or biofeedback and rest. So we use them to selectively improve the quality. Look to this picture. As you can see here, whether it is vaginally or whether it is rectally, of course, this picture shows a woman. It could be a male here. We are going to use rectally. Different kind of probe. We can see this one is a little bigger vaginally compared to the smaller one. So we use different tools according to where we want to treat. And we can use electrical stimulation to help this patient to perform in the best way. So electrical stimulation. As you can see here, the electrical stimulation in red here, which shows that this patient has been reacting. Another thing we can use beside electrical stimulation vaginally or rectally, I have talked about the drain system. These ones can help to improve the vascular system. Another kind of currents specific to help these lymphatic venous systems, to boost them whenever there is edema or post-surgery, whether it is the breast surgery or lolling. We choose different kind of electrodes, patches. We use them to increase the blood flow and reduce the problems. We use biofeedback technique. What is the biofeedback? Actually, the technique of biofeedback consists of receiving the signal, EMG, from the patient pelvic floor muscles, get the signal, put it in the computer, computerize, and analyze it, make it in a nice shape so that it's easier for us to understand. The objective is to reinforce the pelvic command so that the patient can contract effectively whenever he needs to contract to avoid the linkage of the urine or the stool or its gas, effective contractions. We use also these exercises so that patients can understand what's happening, strengthening their pelvic floor and to improve the quality of life. We have negative biofeedback, which is different to a normal biofeedback. The negative one we used for the patient to relax whenever they have hypercontractility of the pelvic hypertonic. We use the negative biofeedback for relaxation. The picture here, the image summarizes the image of the biofeedback. As you can see here on this video, for example, I show here these patients, we can see from the abdominal, the pelvic muscle, they are contracting. Here we use the tool to get the signal and we will analyze this contraction, which is effective contraction for this patient. If we do not have the signal, it will be very difficult for us to understand really what's happening inside these patients. What's happening inside these patients. Abdominal area, pelvic floor muscles, deep pelvic floor, they are working to improve the quality, and then we will work in such a manner so that this patient will have effective contraction and relaxation whenever it is necessary. We use also different kind of the tools. For example, we are using now wireless technology. The picture here you can see it is phasic, fast contraction and the strongest as possible. The patient will follow the graphic we give according to the patient situation. We choose different kind of graphic to help. So here we use a specific graphic according to the patient's need. We don't give the same graphic to everybody. So after the assessments, we know what's wrong for this patient, phasic fibromuscles. We choose such a biofeedback. Here we use a wireless technology using such a tool. We call it a pod, POD, which can provide, as you can see, the signal here, the biofeedback and electrical stimulation as well. We use the interferential pod, for example, the dynamometer, which can get the force in the Newton, the force, the strength of the muscle contraction. We use another capture using another technology of wireless technology. Later on, I will show you in my video how it's worked together. This is the picture of a normal biofeedback, phasic fibromuscles, fast. The patient can contract and relax follow. And this now, you see the concept of Kegel has changed a little bit. Now we can show exactly, not just imagining, thinking what's happening, but we can see how does this patient is performing, connecting to the patient to the computerized tool, which can give us the biofeedback curve, which can help us to guide our patient to perform the right movement to the right exercise. So we use the wireless technologies here, which it's changed really a lot. Just imagine before our cell phone, the mobile phone, everybody, whenever we need to make a phone call, before we need to go to a place and then to dial the number. But now we can call anywhere. Imagine how it's changed globally. The same way happened to the pelvic floor rehabilitation. Before, most of our patients, they have to do only manual treatment. Later on, we create different kind of tools which can capture exactly what's happening inside. This is what we are talking about today. And now, later on, every patient were lying on the table, and then the therapist or the doctor using the finger to ask the patient contract and relax. It's so good, of course, we need that. But besides that, it's so important to let this patient from lying on the table to stand up. Because in our daily life, we are moving. Our symptoms in the pelvic floor dysfunction almost all occurred dynamically, not statically. Those who are suffering from pelvic organ prolapse, ask them. We know that. They will tell you that when I walk, when I take heavy things, this is when I feel them. I feel, the heaviness into the vagina. Those who are having deep pelvic floor pain, usually it's when they're having intercourse, sexual dysfunction. Those who are having leak of urine, whether it is stress, incontinence, most of them, they will tell you that when they cough, they sneeze. So we know that whether it is fecal incontinence and so on, a lot of these symptoms occurred when these patients are doing dynamic movement. So how are we going to solve a case statically when we know in the majority it's occurred dynamically? These questions let us just think how much wireless technology. Today, I don't need just to ask the patient to lie on the table. I ask the patient to stand up, to walk, to run and jump. While the patient will be running, jumping and coughing and linking, I want to see how much the pelvic floor performed. Was there any contraction or pre-contraction? Yes or no? Did this patient have too much of hypertonic of pelvic floor movement when she's running and jumping? So I put the patient actually at her daily life environment, and I try now to treat my patient according to her symptoms. Each patient is unique. For me, each patient is a new book. Of course, this book has a lot of chapters. Some of these chapters, they are talking about the same subject. Everybody talk about urine, stress, incontinence, overactive bladder. It's so easy to say that, but actually we know there are variety of stress incontinence. All of them are not the same. The patient was suffering from overactive bladder. They are not the same. Some of them, it's when they put their key on the door and then they feel that it's time to go. Others, it's when they drink coffee. Others, it's when they are stressed. Their symptoms becomes, we understand that there are a lot of parameters which interconnected, but it's important now to put your patient to her daily life situation so that it will be easier for us to have the clear picture of what's happening at that particular moment our patient is linking or is having a kind of pelvic floor dysfunction. So wireless technology has really improved a lot. More importantly, we know that a lot of pelvic floor dysfunction is taboo. The topic is taboo in a lot of places, even here in Europe. Of course, a lot of patients have been opening up because in France, so early we have started to treat them and using these techniques for over 35 years to 40 years now. But a lot of patients in some area, with their culture background, they will feel a little bit difficult to say, when I cough, I leak. But for us, it's so easy to say, I have coughing, I'm coughing. I can say that. I have no fear. But how many of our patients will take the microphone and say, when I cough, I leak? In our cultures, that's the question. So it's good for us now to give them the chance to talk, to explain that the linking is just a kind of pathology like the others. If you come early, we treat you, you will get better. But when it's too late, we need to do invasive treatments and we know where we go. More importantly, the privacy of each patient is well respected using wireless technology. Why? Because the patient will put the vaginal probe or the rectal probe. After that, the patient is going to wear her clothes. The patient is not going to be just on the table. She will wear her clothes. She will be running and jumping, and no one can even see that she got a vaginal probe there. But what is interesting, we can see the picture. So the patient now will not feel stressed for, because we are not looking inside there with our eyes pointed inside her body, we can say that, but we use the screen to reflect what we need for her treatment. This is a tool. Now we use a different kind of iPad, like, handles. The patient can hold them and do while they're walking. I will show the video later. Same, the Steam Biopod here. This is a multi-patient pod. The patient can carry it at home. Using it, we can download a kind of treatment, give it to the patient, and the patient can treat at home. But the patient should come back to see if she's doing it at the right place and doing the right movements. The advantages of this instrumental pelvic floor rehabilitation is a lot. I just talk about privacy. I just talk about the pictures we show to the patient so that the patient can see what's happening in her body. The patient will gain more confidence. So the patient, we can improve the reinforcing the motor neuron from the head to the pelvic floor. And that can help. The patient can see the improvement after a few sessions of treatment. The contraction, quality of the contraction is going to increase. The patient can see even before the symptoms decrease. Because most of the patients will say, I've been coming here for 10 times, but I'm still having my symptoms. But if the patient can see that avoiding the symptom or treat the symptom is a process, is a long process, and this process will need to improve the quality of these muscles until the ureter pressure will be higher than the bladder pressure while you're coughing, so that you're not going to have the link of the urine. I'm going to ask Isaac on the other side that the timing is it okay? I'm just still have a few slides. Can I continue?
Yeah, you can continue, no problem.
Thank you very much, and I hope that everyone were listening to that. I will take maybe a few minutes. I'm just trying to share with my, to share with you guys my experience so that we can speak in the same, the common language and help our patient, whether it is in Istanbul or in Ankara or in any city there in your beautiful countries, and then or any part around the world. I know there are also some guys watching from Poland. I'm sure we have some friends there and so on. So please, I will maybe go further for that. So the advantages, a lot, as you can see here, help the patient and the doctors to have the clear pictures and image of what's happening inside this patient body. It's so important to have that. We use electrical stimulation, which is a passive way. If I use only my finger, I know my finger cannot be there for 30 minutes. We know that. After 5 minutes, your finger is there. The physiotherapist or the doctor himself will feel tired. So, but using the probe, of course, it can help us to, it's an extension of our hand, but also a very good tool which can capture the neurological function my fingers cannot. So the tool can get what my fingers sometimes cannot, but the tool cannot replace the physiotherapist. The tool is used by the physiotherapist to extend his hand and to get a better understanding on time with the patient so that the patient can improve the motor command, the neural command of the pelvic area and the regions at the particular exercise or at the particular movement. The possibilities to work statically and dynamically. This is really, it's something new. 15 years ago, we could not do it. All the patient have to lie on the table. But now we can ask the patient to run and jump exactly how it's happened on the other side. when she's at home. We can do the same exercises helping her to improve her quality of life. So this has helped us really to treat our patient specifically according to their situations, dynamically and statically as well. My fifth point now is, how should we approach it? I think you have now a little bit of the answer already. We should approach it, first of all, from the non-invasive. You know, from the medical perspective, we know that there is a very famous sentence from the Latin area. They said, prior non seres. If we cannot help, we should not harm. Any doctor has learned it before becoming a doctor. So anything we do to our patient, if these things we are doing can never give any benefit, we should never do that. But so we think first how to protect our patients. So our treatments, before giving the first line of treatment, we should think about this line. Is it beneficial first? And can it give some harm or not? So choose first something which is non-invasive, which is, of course, the pelvic floor rehabilitation. If it does not work, if it's necessary, then we will provide medical treatment or surgical treatment. All of these techniques, we need to master each one. But the question is, which one should come first and why? This image just shows us how the bladder, when it's the anterior pelvic floor, how does it work? Whether it is filling, I'm not going to teach about this because everybody understands it. But we need also to understand what's happening when this patient is voiding. For example, at this particular moment, this patient was voiding. So we know now the ureter pressure and the pelvic floor, the signal here, you can see it's flat. This is the EMG of the deep pelvic floor and the superficial pelvic floor muscles. They are flat. But before you void, there is some activities of the pelvic floor muscles. This is the signal, we see the EMG here. But imagine now, when the patient is voiding and contracting at the same time, of course it's wrong. Especially male patients, whenever they have prostatic problems, they have difficulties to void. Why? Because there is an increased pressure on the urethral region, and this pressure will create some EMG here on the pelvic floor, increase the urethral pressure while voiding, and that is abnormal. So we need to understand it, and this signal, we get it using such a way. So, and we try to understand the continence. The continence is a very complex, how the patient can control the bladder function and void. It's a complex. It's not only about the pelvic floor muscles. They are also neurological, sympathetic, parasympathetic, and somatic system. All of them are working together so that this patient, when it's time for voiding, the parasympathetic system is stimulated, the sympathetic system is inhibited, and then the bladder detrusor contracting, the pelvic floor muscles are relaxing, the patient increased a little intra-abdominal pressure just to start the voiding, the intra-bladder pressure increasing, the ureter pressure decrease, the pressure in the bladder become higher than the ureter, then you start to void. So such a process is so important. There is also one reflex, very interesting, we call the Mahoney, A3 reflex of Mahoney. This reflex is important because each time, for example, whenever my bladder reach about 200 cc, I can feel, okay, it's time to void, but it's not necessary. But whenever I reach 350, for example, then really I should stop the meeting and then go to void, for example. And imagine if I'm still driving my car, there are no toilets, I cannot go to toilet, what I do? I'm using my A3 reflex. So I contract my pelvic floor muscles, so I should know how to contract them. And the contraction should be efficient, so that enough efficient to increase the ureter pressure, but as well to inhibit the detrusor contraction, which was the parasympathetic system, and so that the sympathetic system will activate it again. My bladder detrusor will relax, the volume will increase, and then I can continue to drive my car until I reach home. If I have some symptoms of overactive bladder in some ways, some of the patients, for example, will tell you when they reach home now, when they put their key on the door, then they have to run quickly, otherwise it's gonna be a problem. For example, so we need to understand such a functions and then so that we can help. So intra-abdominal, thoracal, and abdominal pressure, they have an impact on the pelvic floor as well. So we need to combine the thoracal, abdominal, pelvic, and even posture so that we can help them in the best manner. If we don't do anything, and after some long period of time of instability on this region, sometimes we will have the prolapse, cystocele, hysterocele, and this disease has been there since a human being has been on earth. It's not a new topic, but we are seeing patients come in. So is it possible to prevent it? It would be interesting just to talk one day about the topic, how to prevent all these pelvic floor dysfunction in the future. The prolapses occur. So we need to have the history of this patient, take it nicely. Every patient is different. We need to ask, we need to analyze, do the testing manually or biophysically, using the biofeedback to understand what's happening about these muscles. When it's necessary, we use some complementary assessment like the urodynamics. These urodynamics will help us to understand that how does this bladder feel and how does it boil. It's so important to understand this. And then we can do the EMG signals. How does it work? Is there any neurological damage or not? So the strengthening of the muscles, how do we do the testing? And then later on, we will try to see, after evaluating manually, using the anatomy and using the calendar, the diary, how the patient, because each patient is different. So we will try to understand in daily life. Later on, we are going to use manual treatment, and then we are going to use electrical stimulation and biofeedback techniques to try to understand, to put our finger, but also to put a tool which will help us to get the picture and the image on time of what's happening inside these patients. We can use dynamic exercises using the tool at the same time to get the signal and to understand what's working inside manually, assessment to find what is wrong, but also using the tool of the probe vagina or anorectally. All of them are important. It's so important also to use different kind of graphic of biofeedback we are watching here according to the patient need. After good assessment, we know what kind of biofeedback we can do. I talked about pre-contraction reflex. You see here, for example, for this patient, this is a pelvic floor. We put vagina probe. Here, this is the rectal. This is about abdominal. If it's a male patient, I will use the rectal probe here, pelvic, and here I will use the patches abdominally. And then I will ask my patient to cough. When the patient is coughing, for example, what's happening? It's going to happen that the abdominal signal will increase. But I will know now, did the patient first contract the pelvic floor before coughing? If the patient did not do that, for example, here, when we look to this the third time, you see here, first the patient contract, later cough. But here, it sounds like it happened on the same time. So this patient here is at higher risk compared to this patient here, who had the pre-contraction. But if I did not have the EMG, because it's 1/10 second earlier, how can my finger detect the pre-contraction reflex? It is impossible. Our fingers cannot. So we use the biofeedback to get it. We know who does have the pre-contraction and who does not. And then later on, we use different kind of exercises here. Using you see this patient is facing the screen. We give the exercises, contract, maintain the contraction, or contract fast and relax, contract and relax. And we can see the image, what's happening actually. Here we see another patient will be looking to the screen and they will be contracting. I will show you the video just later on. So we use biofeedback techniques, which helps us to put the signal on this patient. You see here, she has already her vagina probe on place. When she contracts, she can follow. Standing, you see she's wearing her clothes naturally, and she can be walking and running 20 meters to 30 meters far from the device and following the instructions dynamically and jumping. This is what we need. This is what we need. And the physiotherapist can teach the patient the right movement, how to do it. Of course, we can do it also for musculoskeletal, the whole body. In the same concept on the pelvic floor is same in the region, as you can see. So I want to share with you this picture about one expert, well-known Maora from working in Netherlands. She shared with us using this device here, wireless Liberty. You see, when the patient have a bad posture, you see her pelvic floor muscles dropped. Can you see the bad? When she gets the right posture, you see her signal in the pelvic floor increase. So there is a direct connection when it comes dynamic pelvic floor, good posture and bad posture. And we see here, when the patient is running, the movement and increase in the signal of the biofeedback, and the patient relax. So the physiotherapist or the doctor will give the right guidance to this patient according to her matters. This is what we are doing now. You see, the patient can do a lot of activities, carry the baby from the floor to the bed, or carrying a box. All this movement we can see in the pelvic floor, just not asking the patient to contract, we know what's happening. So if the patient has a weakness of the pelvic floor muscles, this reaction on the screen might not occur there. And we will help now to treat our patients to reduce these matters. So it's so important. Another video I would like also to share with you. Another video I would like also to share with you. I think it's this one. You see here, this patient now is moving and running. At the same time, she's having her vaginal probe on place. We can ask her, okay, run and contract voluntarily, contract, relax, relax. So the patient can follow the movement on running. We can try to create exactly the same condition our patient is linking, is losing urine or fecal incontinence, for example, and try to treat this patient dynamically. Of course, when we start to do dynamic, it's good to start with statically, later on to move dynamically. All of these exercises, we need them to help our patient improve their quality of life. Another one you see, for example, we use these videos. Here, the physiotherapist is looking to the screen. The patient just concentrates on this video. The patient now, because the patient's mind is on the video, we will try to see now if we treat our patient in the perfect way. Normally speaking, when she's playing such a movement, we will see if her pre-contraction movement are happening before jumping. So we can follow the movement according to her situation. So actually, there are different ways of treating our patients. Pelvic floor rehabilitation is one of them. We believe it should be the first line because it is non-invasive, because it's accessible, because after such a treatment, it can improve even the surgery outcome later on, because if the patient is well prepared, we believe that surgically later on, it's gonna be even better, or sometimes we can also treat them post-surgery as well. So for me, the multidisciplinary approach is so important. After I learned these techniques later on, most of my patients, believe me or not, most of my patients, whether it is stress incontinence, whether it is anorectal dysfunction, whether it is any kind of pelvic floor dysfunction, I combine the assessment of the pelvic floor, and whenever I see something wrong, whether it is the contraction, whether it is the strengthening, whether are the reflexes, whether it's any kind of pain, or even associated with prolapses and other problems, I, most of the time, refer my patient first to get the right treatment. I provide it with my team. We have a multidisciplinary approach. We have some physiotherapists are working with our department. We send them in France. Most of the hospitals and gynecologists, urologists, gastroenterologists, they are working in the multidisciplinary approach. Around their hospital, they have some physiotherapists. They communicate with them, they share with them, and we know it's the benefits for the patients. Because our patient, if he's treated well, we will gain it as well, even we are surgeons. We will get the benefit through it. So after about 15 years I've been learning this, I came with my conclusion that really in our learning process, I know it's so difficult to put also the pelvic floor rehabilitation and so on, but it's so important to work with those guys who master these techniques. You will be surprised seeing how much of effectiveness and improvement your patients in their quality of life in the long term, working in a multidisciplinary approach, it will provide a very good outcome. This is what I wrote here. Surgery, sometimes we need it. When it's necessary, we do it, as usual. But we know whenever you do one surgery, it's not the same that the patient has never had any surgery. On my conclusion, I do not want to go further. We need a global view of the pelvic floor. We need to take a very complete history. Each patient is a new book. Remember this, and we need that. So every patient has the specificity. So we need to treat our patient according to her or his specificity. Our clinical exam is so important manually, and using later on some complementary assessment when it's necessary. And very, very important. We need to know that some of the pelvic floor dysfunctions are extra pelvic floor origin. Sometimes are neurologic, which comes out of the pelvic floor, but the symptoms occur in the pelvic floor. It's so important to have a global view of the whole body, not just into the pelvic. We need a multidisciplinary approach. Doctors, physiotherapists, they need to work together to improve the quality of life. We need every specialty to work together because each specialty has a way of doing things, but we are treating the same patients who is having some problems. This patient can benefit when we share our hand together. In France, it has been done in many places. For example, in my hospital, every week we have like video conferences in a multidisciplinary approach. In our staff, we have a gynecologist, urologist, gastroenterologist, physiotherapist, neurologist, expert in pain, and then we share one case together. Everybody brings his own opinion when it comes to the complex cases of pelvic floor. And we know that a lot of pelvic floor dysfunction is not only just a unique kind of dysfunction. Sometimes it's prolapses combined with incontinence, pain combined with anorectal dysfunction, neurological problem combined with vascular system problem, combined with abdominal problems. So we need a multidisciplinary approach so that we can help to choose the right treatment together. When it's necessary, we do surgery. When it's unnecessary, we never do the surgery. Primal, non-serous, so we better not to harm, but always to provide the right what the patient. Early diagnosis, early treatment, better outcome. Prevention comes first. Always start with non-invasive treatment. If it's necessary, then you know we can go further. Regular follow-up of our patient, it's so important as well. And then, if you don't mind, I finish what I have to present today. If there are some questions there, if you allowed me in a second, I can go.
We have questions, and we can also, if you will not get tired too much, we can.
No, I'm not tired. I've break my fasting already. I've been drinking, so do not worry about me. I hope there you guys are doing fine.
Thank you.
So let's go to see what are the questions I have been given. Okay, I see. Do you think COVID-19 disease had effect on the pelvic floor? Very interesting and hot topic. Actually, it's a very good question, but I never seen any article which has been published recently. We are suffering through COVID even here in France. But here is what I think. Here in France during the COVID, most of the disease in general, whenever it's not life-threatening, we ask this patient to remain at home. Whether it's cardio, for example, when it is cardiac problems, we ask them, hey, you should come because you need to follow your treatment. Those who were under radiotherapy, physiotherapy, they continue their treatment. Those who have, myself, I had some problem, some patient with pelvic floor dysfunction because it was not life-threatening at that particular moment of time. We have the consultation online. So this patient was suffering with linkage of urine. We provided in my hospital, I'm talking about my experience, okay? We had a consultation online. So I was calling them, I was asking what's happening, and then I provide some guidance. How can they try to manage? Because we did not accept them to come to hospital to get the right treatment. So we provided online Those who had already some kind of treatment, we tell them, for example, to avoid carrying on heavy stuffs. So in that manner, we help those patients by giving them online or stuff like this video treatment. But we, of course, we are missing something, because when the patient does not have the right treatment, it's so difficult. But I will go further. I will go further. On my topic today, I don't know if you remember, I said that we have a kind of a pod. We can give it to the patient to carry it at home. I don't know if you remember. I show one pod, I say, this pod, it's like a box, violet one. We can download a program, I said it today, and I can provide that pod to give to the patient, to keep it at home, and do a protocol I download in that pod. So you see here, I'm still treating my patient while we are suffering from the COVID crisis. I will answer also, the patient who are having the symptom during the COVID, 3 months, life distancing, 3-4 months in different regions around the world. Imagine how much do they suffer from the pelvic floor dysfunction. But I will go further than that. Our topic today, we know that there are a lot of patients who have the culture barrier. Like they feel like fear to come to say, I have incontinence, I have fecal incontinence. Some patients, they live with that. Prolapses, they never go to hospital. They think it's shameful. But this has been there from a human being has been on earth up to now. So what I'm saying now here is, if we open up the topic, if we use all the tools we are having today with the new technology, which the patient can follow us online, and the patient can have the right treatment, we can still provide the treatment. We have actually, the scientific and the technological advance has reached to a certain point now. We can treat our patient distantly, we can provide the right guidance, and we can improve their quality of life. So for me, it's not only about the COVID, it's also about our culture barrier. Those who fear, who cannot come because they think linking is something disgusting, but for us, we know it's the same as having any kind of problems. So let's put the information to the public. Let's provide the right treatment for the right treatment, and hoping that this COVID not only is hitting us, and a lot of life may peace be upon those who have left us, and we hope that those who are suffering right now in your country and in our countries, we hope that they will come out of these difficulties. I use this opportunity and this platform to put such a message. So yes, there is an impact in some way or to the other, but we have some answers. If really we want, we can provide better to improve the quality. Very, very nice question. I have never thought about it, but I think we thought about it by providing, like I said, but it was a very good question to share with others. Another question, I'm a PT from Turkey. I listen you with admire and with great respect. I respect all of you there as well. And then a pelvic floor or the treatment are often associated only with women, but men need pelvic floor physiotherapy or the treatment too, maybe more than women because of the prostate or sexual functions work. This is not a question. I just want to hear your thought about it. Of course, I can see is not a question on my topic. I try to emphasize most of the time male and female. Remember, male have also the pelvic floor, the same muscles. I hope next time when we will have another video conference, maybe I will share more slides about the anatomy on the pelvic floor, male and female. I will put them together so that you can see the male, they do not have the pivovagina, but they have the pivorectalis. And the pivovagina muscle and the pivorectalis are just the same. They have the pivococcygis as well, iliococcygis, ischiococcygis. These muscles are the same, levator ani, male and female. Of course, male, they have the prostate there. after they reach to a certain age and they have some problem in the prostate and they have prostatectomy, radical prostatectomy, of course, such a surgery, it's just the same as a radical hysterectomy from women who are suffering from cervical cancer, for example. I worked for about 10 years in the department of oncogynecology, and most of the patients who have a radical hysterectomies, they suffer from, for example, post-void residual. The same matter of those patients, and even link of the urine, the patient who have prostatectomy, radical prostatectomy. I know there are also some studies which has been done when it's come to male and female, show that these patients, male or female, if we give them a treatment before surgery, not the treatment actually, we give them a few sessions to make them understand that how to work in the pelvic floor after surgery. These patients, when they come after surgery, they get the right treatment, they improve faster and in a better way than those who have never had any pelvic floor rehabilitation. We know it as well. Those patients who come for the first time for pelvic floor rehabilitation, their performance is not the best compared to the last time. So as you can see now, male or female, both they suffer from pelvic floor dysfunction. They both, all of them, they need the treatment, but unfortunately, many male, they think they are fine, they are right, but this is just the individual point of view. But most of the society, male or female, all of them, they're suffering in the corner. We need to open up the topic. I'm sure you're going to have, I know I have visited one hospital in Istanbul. I think it's Yadaptep, if I'm wrong with my pronunciation. I visited there, and I know there are a lot of male patients now started to gain some kind of the treatment to improve their quality of life. Thank you very much for your point of view. And here, the frequency table is okay for all types of the currents or only galvanic. Very good point. No, it's not about all the type of the current. I was talking about the current, we call it the rectangular biphasic. You remember I talk about rectangular biphasic current. I talk about the CMLV, which is a kind of a current for vascular system drain. You remember? There is also galvanic kind of current, which is, there is a sinusoidal kind of currents. We call it interferential current. These currents are different current, but all of them are currents. So the table I put there, it's the rectangular biphasic current for skeletal pelvic floor muscles, and I repeat that table. If you remember, the type 1, the frequency was 8, about 33 hertz. The wild of pulse was about 320 to 740 microsecond. The 2A, which is the phasic intermediate fiber muscles, the frequency was 20 and 40 hertz. The wild of pulse, if you remember, it was 160 to about 320 microsecond. And the last one was the 2A fiber type of the current of the phasic. Here, the frequency was about 40 and 80 hertz. And the wild of pulse, if you remember, it was about 20 up to 160 microsecond. That table, I'm giving it to you now in my mind, is the same as I put the picture there. And that table is only for skeletal muscles in any part of your body, the skeletal muscles, using the rectangular biphasic current, which is completely different to the galvanic current, completely different to the CMLV for the vascular drainage system currents, which are completely different. Interferential currents, completely different, because interferential, we use like the frequency is about up to 2000 hertz. You see, complete different. They are deeper, and these ones are just the one for the pelvic floor, superficial, and the pelvic floor muscles. Thank you for me to remind me and to enlighten that point. I'm going to another one. Maybe, yes, okay, this one is in Turkish. I cannot understand, I'm sorry, my Turkish level is not so good. Maybe
she is asking whether it is possible to record and to get the video later on, and everybody
I can see the YouTube here.
The video from our web page.
So repeat that.
The next question. Yeah, I already informed in the chat too. Everybody can reach the video from the website after this meeting.
Okay, many thanks about Ozdal Erson. Many thanks to you. Shukran a lot, and I hope that we will live and have another opportunity one day. Today is the first time, and I try to bring, as you can see, this topic. I try to talk about the pelvic floor dysfunction in general, but when it's come next time, maybe we will focus on some specific rectally only, or chronic pelvic pain, or incontinence, so that we can go deeper in the topic and how really we can choose the right protocol, how to follow and help this patient. When is it necessary to send this patient for surgery? It's so important when it's necessary not to give the surgery and to go first for the pelvic floor. I think these topics need to be told. We need to share all of this. It's so important to give the patient the right treatment at the right time. So I use this opportunity to just enlighten that as well. Do you use any kind of additive medical treatments such as vaginal, diazepam, or biclofen, or the pelvic Botox injury? Okay, you know, I am obstetrician and gynecologist. So I had also my training in all these techniques, including medical treatment, surgical treatments, using the Botox, using the medical treatment. All of these has been told us. But the topic today is, and I would like to share with you, and I would like you guys, each one of you, to think really deep in this topic is, are we providing the right treatment at the right time for every patient? That is my question. In order to answer this question, myself, I had to learn. I had to learn what I share with you today. I went back separately to my major, which they told me how to give the right structure. But later on, when I learned the pelvic floor, the right structure I learned before, I tried even to make it better. Those patients were giving birth without any guidance to just arrive and give birth. I provide the guidance to tell them if they could come earlier, it will be better because this and that. So you see, I started to question myself. This is what I'm asking you to question yourself. Of course, the Botox is given in France. We know some hospital, there are a lot of people using it as well. But we know also some patients, whenever they have the first shot of Botox, some of them, after the second one and the third one, in the long term, they might develop hyposensitivity of the bladder detrusor. So you know, some treatment, if you give the right dose, no problem, you can keep the balance. But whenever your dose is higher than what the patient can bear, sometimes it becomes side effect. So this is why before giving for me, now I understand it, before giving any kind of invasive treatment, I first use all my means to any non-invasive matters which can help. Do you know, today we talked about electrical stimulation. Where does it really come? This comes from the Chinese history of acupuncture. It's not a Western invasion. The Western invasion, or using electrical stimulation, come from acupuncture, which is traditional Chinese medicine. So you know now, it's like we are going back to the source. This is why my questioning now, I'm asking you, are we really providing the right treatment for the right patient at the right time? So if you think about that, if more we learn, more we start to, oh, okay, I can use this one first. Now I know in a multidisciplinary approach, sometimes you can combine both. I talked about first this and then, but sometimes you need both together. If the patient came at the severe stage, sometimes you can provide the pelvic floor rehabilitation associated with other. I give you another example. Those who are suffering with the radiotherapy and chemotherapy after pelvic cancer, like cervical cancer or endometrial cancer, or a kind of radiotherapy in the pelvic area. Of course, this radiotherapy is necessary to save the life of this patient because of the cancer, but at the same time, this patient might have some dysfunction when it comes to the sexual, when it comes to the tissue, the conjunctive tissue, and those walls into the vagina. Remember those players, they're going to be shrink with the radiotherapy, and later on, her pelvic pelvic function is going to decrease. So we need, while we are giving this radiotherapy and others, provide some manual and non-invasive biofeedback technique so that this patient can have, or sometimes drug, local regional treatment to help to improve the elasticity of this region. For me, every player is important. Whenever we lose one, it can have an impact on the whole team. This is why I give you the concept of the pelvic team. So your question, it was a very tough question, but I hope I have answered it in a wild way, this one.
Yeah, dear Dr. Abdullah, we have limited time and anytime we can get a cut and finish the meeting. So we would like to say sorry for our participants while we will have we can get a cut while you are telling the answers. So it seems that we will unable to answer all of the questions because of time limitation. But anyway, hopefully we will have another session which you can continue to answer the questions.
So
I'm
please,
recording.
remember, you have said that, keep those questions there.
Yeah, I already recorded.
We will come back, and I would like really to thank you again for giving me this opportunity to share with you the little experience I have, and I hope that all of you will gain a little bit of that. You'll start to questioning yourself if you are interested in such a topic. If you are facing such kind of patient who are suffering, please feel free to share with us. And I hope next time I will come back with hot topics for the specific in different ways, and I will answer some of your questions. I would like to thank you again, and it was my great pleasure sharing with you in Turkey, in Istanbul, beautiful country. I hope after the COVID we will see each other
hopefully
time in some congresses there. Why not? And I would like to show, I don't know if some of our friends from different parts of the region, they came also to join us. I know some they should be in Poland, others in Belgium. I know some in US and Canada, and in different parts in Europe and Asia. But some in Asia, but they told me that it's going to be at 3 o'clock in Hong Kong and 3 o'clock in Peking.
We have international participants.
Maybe don't forget to put it online on YouTube so that they can enjoy as well. So it was.
So we can continue. I am cutting, sorry, but we can continue the other questions till to our time completely finish.
Next time.
No, this time. I mean, still we have some 10-15 minutes. If you would like to answer in a quick way.
Quick way, but they give me some extra time, so why not? So let's continue.
So we will use all our time. We can continue till to see the end. You can continue in a quick way.
Aklar Koreksi said that I would like to thank the professor for his lecture. I would like to ask how the vocal cord may be affected due to the pelvic floor, or the weakness and the hypertonic. The vocal cord, especially while using the vocal cord. Of course, I know some. I met some of the patients who usually sing. Who usually sing. Either they're professional teachers of yoga and so on. But what I wanted to tell you that I remember one day, for example, I saw a patient who was in the choral team singing, and then she came to give birth. But what we found, I never done such studies, but I remember a patient because you just asked. This patient actually, when we were asking to push to deliver, this patient actually was contracting. So she was contracting and pushing the baby. So she was putting her pelvic floor at high risk situation. I'm not saying all the vocal cord, all those who are singing and others, they have reverse control. What I'm saying here is, if a patient during her labor or during her delivering process or during her pregnancy, you do the right assessment, you find out she has some problems. I'm not saying all of them, they have some problems. Then it's so important to use biofeedback, use external patches to show her so that the patient can see. Because if the patient cannot connect the pelvic floor to what's happening to her mind, to see it on the screen, it's so difficult. The patient, they think they're contracting while you are asking them, but actually they're pushing. or when you ask them to push, they're contracting. This is what I was saying, the reverse command. It's so important now to use the biofeedback technique, electrical stimulations, to show what's happening. If I stimulate, the muscles will contract. So the patient will know what it means contract. And then I can choose some other kind of stimulation for relaxation. So remember this connection between pelvic and the screen is so important for the patient and also for the physiotherapists and the doctors. Thank you very much for your evening. You said they were all very valuable information. My question is, how do we know if the person's problems is caused by the fascia? Very, very good question. I told you about each team members, the members in our team of the Pelvic 4 are important. I gave you the different section because everything has been there, not for free. Remember this, it's not for free. We know anatomically that, for example, if you take the fascia coming from the abdomen, going to the bladder, covering the bladder, covering the uterus, and going to a part of the rectum. This fascia is so important. This is how we have the Douglas wall. Imagine if this patient has too much infra-abdominal pressure, like those who are doing sports with heavy weight. Too much pressure will create some intra-abdominal pressure increasing. This intra-abdominal pressure will go down into the pelvic. So this fascia will find themselves stretched. Whenever they stretch too much, they will use their function, their terms. They're not there just for nothing. This is why sometimes in our surgery, sometimes when we do surgery, whether we do the promotor fixation, for example, we will take, for example, the upper part of the sister cell area, the anterior wall or the uterus, and go to the promotor to bring it back, help these ligaments. Remember, the fascia or the ligament, of course, they are this tissue, which has connective tissue in majority, but they are a part of the team. Everybody is needed. Everybody is needed. We are not going to open surgery to see, oh, there is a hyperelasticity. What I'm saying is functionally, when I do the exercise, I can use the speculum. I can ask the patient to cough when I see the upper part of the Douglas, of the cul-de-sac, coming down. This patient has some erythrocele. When the patient has erythrocele, what's happening? You know, the intestine, they are going back of the rectum, I mean, back of the uterus, and then will create the upper part of the vagina, will come down, and the internal part is the digestive intestine. So you know that this fascia, including the ligament, has been stretched to their limit, and this patient will have the problem of prolapses. So they are interconnected. This is what I mean. We need everybody to remain at the right place at least, so that we can guarantee a normal function. So I hope I have answered your question. Thank you very much for this nice lecture. I thank you too as well. Toshiba PC said that thank you for this presentation. I have attended a little bit late. No, don't worry, next time you will come again. This seems a very practical device for pelvic floor rehabilitation. Can you comment more on the drainage, effective the devices? For example, can I use the patient with the lymphedema? Yes, I talk about it. Thank you very much for bringing this question. Of course, I told you, another question I just answered, that we use different kind of electrical stimulation. We have skeletal electrical stimulation like the biphasic one I talk, and I talk about the CMLV, which is the kind of electrical stimulation we use. Frequency and wall pass completely different to the one I just talked previously. These ones we use, which help only to boost the pulse of the veins and the lymphatic system. They are often used for those patients who have edema or post-surgery of the breast. They're going to have the lymphedema. So we use them to increase the wide of pulse. I show one picture showing that we use the external electrodes. We use the systemic systems. So I'm going, for example, to put on my right hand here, as you can see, an electrode, which covers this area. I will put another one here, okay? And then I will connect to that device to generate a kind of electrical stimulation, which will just increasing the venous system pump. By increasing the venous system pump, what will happen? The blood flow will increase. Of course, we have done it under the ultrasound also, when you use the Doppler, you can see before you do electrical stimulation about the CMLV drainage system, you can see the blood flow, the blood flow, and then after 5-10 minutes later, you do again the Doppler, you will see how much it's increased. This has been used a lot. It's helpful to the patient to decrease the lymphedema, decrease the pressure, decrease the pain, and also it helps also to, after surgery or after trauma, to gain quickly so that the scar also will be covered in a good process. Thank you very much for giving me this opportunity to answer this. We use also the CMLV not only for the lymphedema, but also for the chronic constipation. I did not have much time because it's a wide topic. Chronic constipation, these patients who have the, the intestine, the transit is too slow. So we use such kind of electrical stimulation for smooth muscles. This is what I'm talking about, lymphatic, then, including the intestines, to help this patient and to treat the constipation. So remember, any kind of smooth, of course, we don't use on the brain. Of course, I'm talking about when it's coming to the lymphedema, when it's coming to the intestines. And remember, any electrical stimulation you will be using, make sure that your patient do not have the pacemaker, the pacemaker for heart. It's because if you generate electrical stimulation, which will have an impact on the pacemaker, you can create some other problem. But if the patient does not have the pacemaker, if the patient has the intrauterine device, no problem. If it's a metallic one, no problem. You can do electrical stimulation safely, whether it is a skeletal one I use or whether it's for the smooth muscles. Thank you very much for giving me this opportunity to enlighten. Even a future topic, maybe why not, we will talk only about the smooth electrical stimulation characteristics and parameters. How do we apply it clinically? What kind of the disease, whether it is the pelvic floor or generally, can be used or not? This is another topic, interesting. I would like, I wonder the cost of the wireless Biofeedback. I'm not going to give you a price tonight. I'm not in the commercial. You see, I'm working in hospital as a doctor, but I know that this tool is so important. It's changed really something, believe me. And I did not tell you one thing. The tool I'm using, the Phoenix Pro, it's a Phoenix device actually. You asked me a lot, so I give you, and I know I give the reference there. This device actually, it got the first prize worldwide. Combine electrical stimulation and biofeedback at the same time. First wireless technology combining electrical stimulation and biofeedback. That is a product I just saw you today. So you just imagine it won that first prize. It was in 2012, if my mind is okay, here in France. So I know such a tool, you have it there in Istanbul, and maybe why not in some cities there. And it can be, now we are living in a small village. The thing I'm talking now here, I'm sure it's there already. About the price, I'm not in the commercial, I'm sorry, I will not give you the price. But I'm sure that it's worthy when it's come to how much you can provide to help and to achieve your patient. Which center? I think you need to connect to the panelist, the one who organized the platform, the E6 setting who sent you the invitation. She will give you more information because I have to go through the other question. Thank you very much for your presentation. I am a pediatric urologist in Istanbul. Thank you very much. I did not talk too much about pediatric, but remember, they are also included in the multidisciplinary approach. Here in France, we also use the same techniques, believe me, same techniques treating pediatrics. We don't use the vagina probe. We don't use rectally most of the time, but we use external patches for those children who are suffering from pelvic floor dysfunction, and we help them also, and the children, they enjoy because we can use a funny way, a lydic way, funny way to help them playing the game, but actually treating at the same time. So do you have any experience about such a thing? Of course, I've been in different parts around the world. I'm obstetrician and gynecologist, I'm not treating pediatrics, but I know in different lectures I give here in France and overseas, there are a lot of the physiotherapists who came and attend. The techniques is the same. I teach the same techniques to all of them. Now the approach is different, as I say. The approach is external electrodes. We use it more because it's non-invasive for the children. We cannot use rectally most of the time. We cannot use it vaginally. for those female pediatrics patients. But what I know, there are a lot of teams which are well experienced using the same device wirelessly and helping this patient. Because just imagine, because I know pediatrics, it's a barrier. How can you avoid, how can you go to give such a treatment to the child? Imagine now if you can do it, the child is wearing clothes and they just external electrode, the child is looking to the screen, you put some lydic games, but actually with the contraction and relaxation, you can treat chronic constipation, you can treat some kind of incontinence after trauma and so on. So remember, this is well developed. The principle, what I talk today is exactly the same, using the same parameters. Do not forget, when I say same parameters, the difference is the intensity of the current I will be using for each patient. So it depends on the sensitivity of the patient. So each electrical stimulation, the patient should never feel the pain. It should be comfortable. It's so important. This is why you can, it's so important to use the best tool to provide exactly a good kind of sensation so that the patient can never feel uncomfortable. And whenever the patient does not feel uncomfortable, the door is always open for reaching the problems of your patient and treating them. But whenever the patient feels that the privacy is not there and there is a painful environment, the patient will be very stressed. Children, we know, sometimes we need to sing sound to just give them a small injection, to make them feel happy. Then we use the same techniques. Principle, exactly the same, the approach different. Thank you, COVID answer. Thank you for the COVID answer. Thank you very much for asking it. I'm going to share this topic, but actually we are trying to provide. Remember the core. Sometimes we need to touch the patient, but we can form them as well. How long can we use the maximum anal electrotherapy as old patient if there isn't any progressive when we should stop electrical stimulation? Thank you very much for this question. Actually, the timing of the treatment is depending on the characteristic of the fiber muscles. If you remember, I talk about the tonic fiber muscles and the phasic fiber muscle. I talk about the type 1, type 2, and type 2A and 2B. Actually, the type 1, this is what we call the tonic. When we talk about anorectal, we know the sphincter fiber muscles are superficial fiber muscles, and they are about 90 to 80 to 90% phasic. External anal sphincter. It's a phasic fiber muscles in general, about 70 to 90%. That means there is only about 10 to 30% of tonic. So if this patient have, for example, anal incontinence, it does not mean that the tonic, the minimum of the tonic percentage, that are not important. And we know also when it's come to the anal function, the tones, the basic tones of the anal closure at rest is based on the internal anal sphincter, which is smooth. I repeat again, it should be very clear. We have the internal anal and the external anal sphincter. When this patient is at rest, sitting like us, we are talking now, we are not contracting, our anal region is closed. And this closeness of the anal depend on the internal anal sphincter, which is smooth. That means the anal tones depend 80%, majority, about the internal anal. But it got the external anal sphincter, which is in majority skeletal type, type 2. So I need to do the anal manometry first assessment to see the anal profile, to see the reflexes, inhibitor reflex, the contraction reflex, to see how much the patient can do. And then later on, after I do my assessment, I know this patient has dyssynergia problems or not, caused by constipation as a symptoms, or this patient has fecal incontinence, her closure pressure of the anal is weak. After I do the assessment, now I have the idea where I should strike. How can I help? Electrical stimulation I use as a passive. I'm not going to use it for 1 hour. Most of the time, when it's come to type 1 fibers, 15 minutes, it's okay if it's electrical stimulation. Type 2, remember, they are phasic. These muscles, they use glycogen. That means they will get tired very soon, external anal sphincter. You cannot, even you, if I ask anybody here, just contract strongly and keep it strongly for 1 minute. We cannot. After a few seconds, we will feel tired. Why? Because we are using external and voluntary to contract, which are physic, which are weaker. I mean, they get tired earlier because they use too much energy. In such a matter now, when we do the treatment, we should also respect the characteristic of each fiber type muscles. When it's come to the anal, it's so important. If you use the parameter of the physic, remember, I said there, 2A, the table. If you remember the table I projected, the 2A fiber muscles, if you remember, I said it's about the frequency, it was 20 to 40 hertz. The one parts, I said it was about 16 to 200, 320 microsecond. And I said also the timing of the rest time is double. It's double. I said rest equals to 2W. That means that if I give the patient, for example, 5 seconds of stimulation, and then I should give 5 seconds of rest because I use the parameters of physic. So you know now, the timing I will use to stimulate my physic, I should give too much time of rest, otherwise it will be harming. Primal non seres, you remember that sentence, do not harm, if you cannot give something better. So if you understand that chemistry, another thing, I said tonic, okay, 15 minutes, it's enough. 2A, I can say, okay, 10 minutes, and 2B, only 5 minutes. So more you use energy, it's just like you. Physic, fiber muscles, I just looked at them like Usain Bolt. Usain Bolt, you know, the marathon, who ran 110 meters faster. You know, they ran 110 meters in less than 10 minutes, 10 seconds, I mean, 10 seconds. So in that manner, after 10 seconds, they are tired. But the one who ran marathon, 42 kilometers, he can run for a few hours. So endurance. So type 1 is like a marathon athlete who will run the 42 kilometers. We don't need to ask this patient to contract too much, just halfway and maintain. That is type 1. Type 2 is faster. But when I do faster, I should reduce the time of work because these muscles will be tired. I hope I have answered it. And if it's necessary next time, I will come specifically explaining how do we choose the time according to the patient assessment. Your questions, if I really need to answer, I have to give the whole picture. This is what I did. I hope I have answers. Thank you for amazing lecture, Dr. Ndongo. Do the phases of the menstrual cycles have an impact on the pelvic? Good question. Most of the time, whenever they have, you know, when they have these menses, you know, which will come for 1 week, we just, because hygienic environment as obstetrician and gynecologist, most of the time, even for our assessment, when in gynecology, most of the time we tell them, okay, we will do it next week. But remember, your treatment is about twice a week. Twice a week. So this week I did not do a treatment after the menses pass, and the next time I come back, I treat the patient. I can do my assessment for 1 day, but it's good to leave this patient after the menses. Why? Hygienically. Because during the menses, do not forget, there is a connection. This is the only reason, okay? It's not functionally, it's not because of the function, but it's hygienically, potentially important to leave this patient. Why? I explain. Because during the menses, do not forget, as a gynecologist, there is a direct connection between the outside wall, the atmosphere, vagina, intra-uterus, and even into pelvic. This is why women often have pelvic, intra-abdominal infection and others. Why? Because during the menses, the barrier, the cervical, you know, the cervix has a mucus, a kind of secretion, which provide defense. But during the menses, this defense, the door is open. So for us to bring the tools there, do the electrical stimulation, and the patient usually they feel uncomfortable. So you better leave them after they finish the menses. The next time they come, you provide the best treatment. You can, the day she got the menses, you give her the anatomy, you explain how to contract, how to relax, to imagine, you can show the picture, you see, you can provide some others, not instrumental. You know, you can provide abdominal posture, but not use vaginally treatment to use other tools. So this is my experience. This is what I think a lot of people here in France, they do the same way. And And I hope you can provide the same. Why not? You can compare between these two, but I think many patients will really enjoy. If you put yourself to the patient place, you can see the answer you got it already. You better wait next week and provide the treatment. Thank you for that. It was amazing to listen to you. You are so energetic. Everybody is energetic because I got my glass here. Even I've been fasting, but I use my glass of juice. So the energy comes, I cannot see everyone there. But as I imagine, you guys are watching, so how can I cannot have an energy? So you gave me the energy. This is why I'm here. Okay, thank you very much. So you are so energetic. I wish I could be your student. Oh my God. I'm not a teacher of anybody. I'm just sharing my little experience with you, and I hope that from these exchanges, really, I'm learning from anybody as well. I exchange with neurologists, gastroenterologists. I have respect to anybody specialty. I learn a lot of things from physiotherapists as well, and this is the way we can have, I can say, a clear picture of what's happening. My advice here is open your mind early, be receptive to different concepts, think about it, read a little bit, and then we learn more. That's it. And then the question, is there any technique, evaluation, PFM or contraction without using the finger? Of course, or the probe. Of course, we most of the time, if you don't use a probe, sometimes the patient, when the patient contracts, you don't know. The question is that. But today now we are developing a lot of assessment. I'm sure in the near future we'll bring that. It's external association. I talked too much about posture, you remember? And we know that the posture has an impact on the pelvic. I show you the video of one of the experts. I don't know if you remember, when the patient used a bad posture, and we know the EMG changes. So now we are using combining that with external evaluation of the posture. We are going to have even a clear picture, posture, combined to the pressure and the EMG together, and to analyze it. So I'm sure these things people are working hard to provide it, and I'm sure in the near future we will have different kind of devices, but which will combine different specialty to help us to understand better and to have a good assessment which reflect the reality of the patient, so that we can provide a specific treatment according to each patient. Every patient cannot get the same. I am a student, a PT student from Turkey. I am interested with the women health. What are your suggestions for the PT students? How we can enhance our knowledge more? Any courses, suggestions? First of all, you came here, you came to the right place. This is number one. You get a little bit here. Second, be open. This is what I say to different congress, different meeting. Read a lot. We should learn. We should learn from one another. Get the contact to those who are well experienced as well. Learn from there. Exchange it from the other students who got some hot topic. Take some of the little of your time to come to learn from different platforms. I think we have now different ways of learning. This is why we are using this. I remember when I started to learn medicine, I have to go to the courses. But later on, I started to go to different congresses. Later on, but I think the good thing you should be doing also is each thing you learn, you should come back and try to analyze it, okay? And try to put it into practice. Because knowledge without practice, sometimes we lose it. So put it into practice. The things you will be talking, it should be reflected the reality. And learn more, and more you learn, better you will be. So you are welcome at any time again. We saw apps like Xbox, yes, to train the patient dynamically, okay? Do you want them to contract and release? Okay, remember, when I was showing the Xbox, of course, I'm not taking a patient who just come for the first time, an old patient who is suffering from urine incontinence, and then I put the Xbox. No, this concept I'm showing now is when really this patient has been treated statically and gained to a certain level, you put this patient dynamically, you treat before this patient go back to the society. Because you know, one day she will be watching the TV. On the TV, she will saw her grandson or daughter who's about to fall down. So she does not have to think, oh, first, before I help this child, I should contract my pelvic floor. The child will be already go down. So we use such a reflex, just a kind of a test or a kind of a pre-test before treatment or after effective treatment. It's before you leave this patient to go to, to the normal life, remember. And remember, every patient is different. There are those, imagine about those sportives. Imagine the Turkish female basketball team or football team. In France, they did a study which showed that in those schools of teams, these teenagers have been trained from early age. Most of them are developing a kind of pelvic floor dysfunction before even childbirth or becoming adults. So now we know that if we don't give the concept to those coaches in different schools about national teams, now in France there is such kind of concept to teach, to have meetings with those coaches in different schools so that they can, when they ask these children to jump basketball or trampoline or whatever it is, so to make them the concept of intra-abdominal pressure increase, or when you do the crunches, these crunches increase too much intra-abdominal. Can I do another exercises without doing crunches? Of course, yes, without increasing intra-abdominal pressure. So this will change even the way how we train. So for me now, remember the Xbox was just an idea to show you we can go further, but do not take it as a classic. If we need to implement it in a good manner, to use it when it's necessary, too much of anything becomes not good. So remember that. So this is what I believe, and I think you can try to put it in practice. You will see by yourself, according to your experience. Thank you very much for your wisdom. We are okay. Thank you. I'm finishing. Can you tell us about it? Use the post-radical prostatectomy incontinence. Of course, I hope, and maybe today I'm not talking too much about it, but remember, as I said, when we do radical prostatectomy, you remember we need to save this patient's life because of cancer, okay? So the surgeon, the urologist, will try his best to give the best surgery as possible. By cutting this disease and helping this patient, we know there is a direct connection to the urethral closure pressure. And this pressure, whenever it's damaged, this is why this patient after surgery, most of them, they have incontinence for a couple of months. Some of them, it's cured. The others, they need to go under pelvic floor rehabilitation. So it's depend on how much this region has been, damaged through this life-saving surgery, okay? And now it's good, it's so important now for us to help them early as possible so that they can have a normal quality of life. So this is how I say, remember, it's exactly the same radical hysterectomy, especially type 4 or type 3, okay, hysterectomy, which damage the uterosacral ligament, and inside the uterosacral ligament, we have some sympathetic and parasympathetic system, and these nerves are interconnected to the functions of the bladder and the urethra, and later on this patient will have some kind of urethral bladder dysfunction, incontinence, or post-residual. It's similarly to male, female, because male or female, both, all of them, they have the pelvic floor, and all of them need right treatment at the right time. Again, for the second time, thank you very much, very, very much for giving me this opportunity to answer. And I would like also to give a kudos to the one who gave the idea, which is ESSEC setting, to bring all of you together so that we can share with you the little we have. And we hope that next time we will even share more and more. If you are interested to these topics, you can write to her, and then you will choose a topic which is interesting, and then I'm willing to share with different experts from your country there. Why not to learn from them, because I know they are very good experts as well there who can improve and continue to improve the quality of life of your people and to anyone around the world. Thank you very much again, and shukran.
Dr. Abdullah, we are really thankful. Once more, we admired your energy, wishing God's support to you, and we are really thankful for your support to us. All the things that you tell us here really very valuable, and all our participants send their best wishes to you in our chat box. So really thankful for your assistance to us and support.
Thank you very much. We will continue to work together and to improve the quality of life of your patient there and anywhere in the world. Thank you very much.
Thank you. And I am also thankful to all our participants here who stayed till to this hour. And we will be continuing to do such programs in the future, hopefully. And we will appreciate if you can trace our website, Pelvik Academy. Then we will be in touch, all of you, again. Thank you for this attendance.
Thank you.
Good night.
Thank you very much. We need them. Without them, we have no energy. So my energy is the feedback, wireless feedback from you guys there. Thank you very much.
Thank you. Thank you very much. And good night to everybody.
Shukran, and then hope to see you again. Thank you for everyone.
Soon, hopefully soon. Thank you. Thank you. Bye-bye.
Thank you.
And good night to everybody.
Thank you very much.
See you soon.
Good night. Bye-bye.